And the next section is literature review, correct, Simon?
Yes, literature review.
Okay, over to you.
Everything I'm going to teach you to do is evidence-based. So we're going to explore that literature. I need you to understand that early intervention is no longer practiced in orthodontics. We need you to be able to rationalize and justify anything that you do when it is no longer common practice. So I'm going to help you with a series of steps that will make your decisions logical and progress in a way that makes sense to you, makes sense to the parents, and makes sense to the King's Counsel who represents the dental board when they will occasionally ask to review your cases. I need you to be safe. And in order to do that, you have to understand and be able to explain everything that you're doing with evidence to back up everything that you provide. So what's the evidence for early intervention? Well, Tulloch in 2004 ran a randomized controlled trial, and he basically said it's a waste of time. So in the grand scheme of literature, randomized controlled trials are level 1 and 2 evidence. All right? So that's basically fact. They found in 2009, when they ran a multi-centered randomized controlled trial, all right, this is AJODO, so this is a top-tier paper run by top-tier universities in the UK, peer-reviewed by the top-tier reviewers. Kind of works, but it really is a waste of time. All right, early intervention sometimes works, but predominantly it's a waste of time. Cochrane database. So this is level 1. This is a compilation of top university professors who review randomized controlled trials and make recommendations to our profession. You can use face masks, but the evidence is weak. Sunak, 2015, systematic review. Again, a level 1 evidence basis. Review of literature. Don't bother, it's a waste of time. When we look at systematic reviews of the high-level research done, it tells us, doesn't work enough that you can justify providing this treatment. 2017, wound, systematic review, only a moderate level of evidence for class 3 interventions. Batista, 2018, Cochrane review. There's no advantages of doing a phase 1 therapy. So orthodontics is broken up into phase 1 and phase 2. Yeah? Early intervention before puberty, primary dentition, mixed dentition, and phase 2, permanent dentition. We're advised, we're recommended, we're told, just put the braces on, dude. What's the evidence for functional orthopedics? Another form of early intervention. 2010, Angle Orthodontics, again a top-tier review. Doesn't work to change skeletal base. Corizzi, systematic review, meta-analysis, European Orthodontic Journal. Again, top-tier orthodontic paper, level 1 evidence. Don't bother trying to treat class 2 malocclusions. Systematic review, AJODO, top-tier journal in the world for orthodontics, 2016. Functional appliances with multi-bracket appliances have no skeletal effect on the mandible. Fascia, 2016, a systematic review. European Journal of Orthodontics. Little evidence, effectiveness of fixed and functional appliances in class 2 malocclusion. What about myofunctional therapy? Is there evidence? Not really. Systematic review, Dental Press, Journal of Orthodontics, 2014. There's not a lot to support this type of therapy. What about sleep disorder breathing? Is there evidence? Cravallo, 2016, a Cochrane database. So this is fact as far as the orthodontic community is concerned. Insufficient evidence to support the use of oral appliances and functional orthopedic appliances for obstructive sleep apnea in children. Ching, in 2018, a systematic review. What is the benefit of expanding the maxilla in sleep disorder breathing? Nothing. What about how occlusion comes about? What evidence do we have that it isn't genetic? Not much. Facts seem to show that what the parents have, the kids have. Moreno, Urbi, 2015. What's the genetics behind class 3? There's actually genes that are found specific for class 3. So there's an irrefutable genetic link to class 3. So why are you here? Like, why are you here? Just for the coffees and pastries? What does our profession believe? This is what orthodontists think of us. We're just hobby orthodontists. Good old Rob. There's only a few of us of this generation who remembers Rob. Can't show his face because he's a dentist. All right, let me give you a different perspective on evidence. Pancheres in 1997 confirmed that class 2 skeletal malocclusion is the same whether it's division 1 or division 2. All right, the only difference is the teeth are facing out or facing in. Millett in 2018, level 1 evidence, right? Cochrane database, level 1 evidence. This is fact. There is no evidence from clinical trials to recommend or discourage any type of orthodontic treatment to correct class 2 division 2 malocclusion in children. Who has ortho in their practice? Who has class 2 malocclusion in their practice? We have no evidence to treat that at all. This is to the orthodontist, right? You know that, right? There is no evidence to support treatment of class 2 malocclusion. That's half your practice, isn't it? And I'm talking to the orthodontists in this community, not the general dentist. There is no evidence for you guys to treat class 2 malocclusions other than surgically. You know that, right? Orthodontists don't look at whether the kid's mouth is open or not. What about the anthropologists? How do they look at malocclusion? Well, apparently, it's environmental. Apparently, when you actually do science and not just dental science, we find that it's not just genetics. I used to just read through these slides, but I'm going to ask you when I give you these PowerPoint, saved as PDFs, to go down the bottom there and look at the reference and get a copy of the literature and read it. Right? Everything that I've put on this weekend is part of the library that you need to be able to face up to the orthodontist who says, what the hell are you doing? Because you will have orthodontists who say, not to you, but to the parents who go for the second opinion, what the hell is he or she doing? And when you need to defend yourself, this is what you need. It's not heritable. Right? When real scientists study humans throughout history, we don't get that, oh, the father had it, so the son has it. When we look historically at skulls, we don't find the things that we see today in the last 100 years. What about the geneticists, the scientists who study genetics? It's too short a timeline. It takes 1 million years for something to change in a biological system. We know that there's a shift in face shape, very rapid shift, like measured in hundreds of years rather than tens of thousands of years, which is what you would expect for natural selection and genetic change. When we look at the face and we study it using science, we know that there are some parts that are inherited and some parts that aren't. And guess what? The parts that we work on aren't. There are things called epigenetics, which allows the environment to impact how your genes express. That's not the same as genetics. We know that there is a very big body of science outside of dentistry that is actually interested in what we as human beings are evolving and changing into. When we look at epigenetics, we want to make sure that we have an understanding of it. So read it, because it helps you understand how the world around us affects us. There is a complex system, but you have to be able to explain it. Because if you don't understand it, the parents won't understand it, and the King's Council representing the dental board won't understand it. Ice cream, fairy floss, hamburgers. There's a link. You know, when you say, would you like the Brussels sprouts or the ice cream? There's a link to how the children respond in compliance. We've studied identical twins, and we've realized they're not identical. They express very differently. So you can have in the same part of your body two genetically different components. Right? There are things that are present in the world of biology and genetics that we have to explore so that we can believe that, hey, we can make a difference. It's not like the color of your eyes. Relapse. It all relapses, you know that, right? All orthodontic treatment relapses. It really doesn't matter how good you are as an orthodontist. Your goal is after 16 never to see that patient again. You know that, right? That's the goal. Round them up at 12, and then please never come back again after the final records. Go see the general dentist. They'll look after you. Please spend the time, find the papers, read the papers. We know that there are growth changes throughout your life. That taking a child between 12 and 14, that window of change where it's easy to move permanent teeth is only a slice of their life. We need to have a bigger view. Certainly as generalists, it's cradle to the grave, right? Cradle to the grave. Now, if you sift through the literature, there are actually randomized controlled trials that show we can change skeletal outcomes. So Mandel in 2016 ran a 2-center randomized controlled trial, and they were able to prevent many of the class 3 children from needing surgery by starting early and putting a face mask on. We know that surgery is not the only answer. There is evidence. We know that myofunctional therapy works when it's done with logic and smarts, and not just as a, let's see if we can prove that this doesn't work. We know that the mouth is part of a bigger ecosystem, vital function, right? Your life is dependent on vital function working effectively and efficiently. When you pull the maxilla in a class 3 patient, it reduces obstructive sleep apnea syndrome in children. Systematic review. So level 1 evidence. We know that when we study it, not just in the orthodontic department, but when we study it with ENTs and when we study it with sleep physicians, we find that early intervention improves the dimension of the pharynx. We know when we are seriously utilizing myology professionally, systematically, logically, we can improve obstructive sleep apnea. We can add and support surgical interventions to get a bigger overall improvement. There's evidence to prove we can help. We can't help on our own, but in conjunction with real doctors who treat obstructive sleep apnea, we can make the patient's lives better. See, a lot of the studies are orthodontists trying to improve sleep breathing disorder. Well, they show no improvement. But nothing happens in a vacuum, right? Everything together makes the real difference. Villa is a sleep physician, Italian-based. 2017, when we improve tongue tone, we improve sleep disorder breathing symptoms. We improve oxygenation of children. We have recommendations by the European Sleep Society for orthodontic intervention. They say when a child has sleep disorder breathing, the orthodontists need to help us out. It's recommended in the European Sleep Society recommendations for European medical intervention. It's Article 6.6. Do something. Dentists, orthodontists, do something. These children will benefit. Make custom-made appliances, expand. Help us out to help the children out. That is the official recommendation. What about growth? The top and the bottom jaw, they grow independently of each other. The top jaw does most of its growth in the first 5 or 6 years. Why would we wait until it's finished if we want to guide it? We take a 12-year-old and say, well, that doesn't work. Well, it's because their maxilla stopped growing years ago. We know when we study growth that we can pick up skeletal malocclusion early and it doesn't fix itself. It won't outgrow itself. It won't get better. It stays the same and sometimes it gets worse. So if you want to do something, why are you waiting until 12? And why are we treating in a way that isn't evidence-based at 12? Even though we say, as an orthodontic profession, we only do evidence-based dentistry. But the Cochrane Review in 2018 said that there is no evidence for class 2 correction. Well, in my hands, it works. Well, you can't have your cake and eat it. You can't tell us there's no evidence, so you can't do it. But I can do it even though I don't have any evidence because I'm a specialist. All right, so this is how we take the stand. We do our research, we do our homework, and we find the evidence. Or if there isn't, then we say there is no evidence basis to this. Just like there's no evidence basis to class 2 correction, right? We're open and honest. Like, it gets the children better, but there's no evidence for it. Just like when you see fixed appliances at 13 and class 2 mechanics makes it better, even though there's no evidence for it. The mandible continues to grow and grow and grow and grow for years to come. So we have to understand that they're on 2 different timelines. So treating in the middle of the peaks of growth is not as smart as treating early so that you don't have to treat in the middle so that you can tidy up at the end. Why are you waiting for it to get worse when you know it's going to get worse? That's what the evidence tells us. And then you say, well, you need surgery, clearly. And the parents say, well, is there anything else you can do? And I says, well, we can try this. Well, why are you backing down then? at 13, the boy comes in, class 3, needs surgery. So he needs surgery. And the parents say, oh, please, is there anything else you can do? And what do you say? No, there's nothing else we can do. He needs surgery. But what do you say? Well, then we can try this. Take a stand. If you wanted to try that, you should have done it when the maxilla was still growing, right? Not after it's long stopped. High angle. You can pick it a mile away before 6, and it just gets worse. Low angle. You can see it straight away, deep bite. In the primary dentition, what do you think is going to happen? It's just going to magically disappear? It's a skeletal problem, right? 21% of the population is class 2, 7% of the population. So a third of the children who walk through the door have a skeletal problem. These are the ones you actually need to help early because they're not going to get better on their own. A third of our population, a third of our children are severely handicapped by their malocclusion. Like I have very bad vision, right? I've got terrible, terrible myopia. Right? It was picked up grade 3 that I had terrible short-sightedness. Did the optometrist say, let's wait until he's 13 so that he won't lose the glasses? Or did he say he's really terribly short-sighted and handicapped? Would you like us to help correct his vision so he's better off now? Which optometrist would my parents want to treat me? The one who's trying to save you money so that you only have one set at 13? Doesn't matter which part of the world, it's about a third of the population with skeletal malocclusion. It's the 80-20 rule, right? 80%, you can wait it out. Of course you can wait it out. It's just dental malocclusion. But there's 20% that get worse. And unless you are adamant that you're going to treat them surgically, and you're not going to give this a go, then sure. But if you're going to give this a go, give it a go early. How is it any different to give it a go later?
5 minutes. Thank you.
So we know this is throughout the world and it's common. Far more common than historical records indicate. Like impossibly more common. 5–10% at most is the normal skeletal malocclusion range in historical times. How can it be close to 30% of the population being deformed, right? This is the deformity, yeah? Yeah, if one leg was 80% the length of the other, would you call that a deformity that was interfering with me and handicapping me? So how many kids have that imbalance in their jaws? About a third, right? Well, let's just wait until they're 13, they might grow out of it. He doesn't need to run, I'll teach him how to drive. When he's 16, right? It's everywhere. It's in your practice. It's a third of the children that you see. It's a third of the adults that you see. It's a third of this room. Who's got a skeletal malocclusion? It can be picked up in preschoolers. It can be picked up in primary schoolers. It's obvious. And you can see a lot of them have sleep disorder breathing. Cross bites, overjet, overbites, underbites, open bites. There's a link to sleep disorder breathing. Oh, but you can't change basal bone. The amount of basal bone varies according to your malocclusion, according to how your teeth erupt. Who's seen a molar, an upper molar touch the lower ridge of a dentulous patient? How much alveolar bone is in that little segment of the mouth? Can you push it back up? No. With TADs and chain and whatnot. So we can control alveolar bone. We can't control basal bone, but we can control alveolar bone. Do you know what proportion is basal? Who's had to do full mouth clearances on older patients and then supply them with dentures? Who's had to replace dentures that you did a full mouth clearance on 25 years ago? How thin is that basal bone? How thick is that denture? All right, the thickness of that denture is the basal bone. And you look at that little pencil of mandible basal bone, and you look at that mass of denture that represents the alveolar bone. So think about that. We can affect alveolar bone, tick. We can't affect basal bone, cross. But how big is that basal bone? It's teeny tiny. Our control is enormous. We're just not seeing the right perspective. And that ends literature review.
All right, terrific. Thank you. So we're just 10 minutes behind, but I'm sure we'll make up for a little bit later.
So we're going to have an addendum.
Oh,
no,
addendum?
addendum to the literature.
Okay, let's continue then.
So one thing that I spoke to you about is I'm only teaching what is evidence-based. So some of what I do is called orthotropics, and some of what I do is called postural orthodontics. Postural orthodontics is heavily evidence-based. Orthotropics, which is aiming to change skeletal growth, is light on evidence. So what I've been doing in the last 15 years is to try to create evidence-based. So I've been working with the University of Texas, A&M, and we did a study on my hyperdivergent high-angle open bite cases. We submitted consecutively treated cases, and 47 hyperdivergent cases were selected for the study. And we showed that I was able to make positive change to growth of the skeletal base. This preliminary study showed that bioblock therapy produces significant improvements of AP maxillomandibular skeletal and dental relationships through anterior mandibular displacements and changes towards a more horizontal direction of mandibular growth. We used John Mew's orthotropic technique. We traced the X-rays. and we found statistically significant changes in AP, and specifically the mandibular growth. So we reduced A and B. Fiber-block therapy produces significant improvements of AP and maxillomandibular skeletal relationships. It produced significant molar corrections and reductions in overjet, changes in mandibular growth in a more horizontal direction, and does not have negative effects on mandibular divergence. So hyperdivergence is the most difficult of all malocclusions because growth makes it worse. Because the two jaws are facing apart, and as they grow, they get further apart. All treatments that are non-surgical increases the divergence. All right, everything we do in orthodontics adds vertical, which is fantastic for the deep bite, right? But it also adds vertical to open bite patients. So that always makes it worse. So we don't actually have any effective treatment, non-surgical effective treatment for hyperdivergence. So what we're trying to do is figure out, is there any treatment that can work? And so far, we've come up with nothing, but hopefully something from my research. And that ends literature review.
Okay, terrific. Thank you.